Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 147. It's a lovely September morning here in New York City, and it was a joy watching the new introduction. We are continuing our theme today of managing very highly calcified complex lesions. This may be the third consecutive IV lithotripsy case. In fact, it may be a RotaTripsy as we have come to know it better. In addition, this is also complex because we are doing a case through a previous TAVR, and there would be issues regarding accessing this, which will, of course, all be highlighted and I'm sure answered. With this introduction, let me take you to the cath lab where Dr. Sharma and Dr. Kinney are already there. Samin, good morning. We continue to make advances, teach more and more of the RotaTripsy, huh?
Yes, RotaTripsy, RotaShock. I think the field is still out there, what name we are going to say. But good morning to our viewers, and we try to produce and present the challenging cases because, of course, there's always a learning, whether it's a simple or tough. But in this particular case, we felt now there's a more and more patients are coming who already have a valve, TAVR valve, and more so importantly from the self-expanding valve. Of the Evolut or core valve, and then if you have coronary disease, access is quite tough, and that's where actually we'll talk about. Anu had made the app also, so I think this is a very important field which is coming up, and we welcome from Mount Sinai Cath Lab with my Anu on my left side and my fellows and rest of the Cath Lab staff. So with that note, we can quickly go to our presentation. So we get on to it. I know we're a few minutes late. These are our supporters, and the rest unchanged. So this is a case number 147, as you said, 75-year-old patient. Patient actually presented in 2007 with unstable angina with severe two-vessel disease and left main, for which I sent her for CABG. She did fine over the years, then developed a little bit of shortness of breath for last few months and found to have more dyspnea, and as well as seems to be more of a symptoms of aortic stenosis. She developed AS over the time period and has a heart failure with reduced ejection, with preserved ejection fraction. So basically, because of progression of the aortic stenosis, and in the past, for the TAVR, we used to do angiogram beforehand. Now with post-COVID, we want to minimize the patient's visit to the hospital, and we do cath at the same time. So patient was planned for the transfemoral TAVR. That too has a bad iliac disease, so require with the Shockwave, and then did a percutaneous transfemoral TAVR on July 27. So at the time of the TAVR, we did the angiogram and found 3 vessel, of course, patent LIMA to LAD, SVG to OM. So they were good for last 13, 14 years. So bypass is good, but now has developed significant lesions in the RCA. Now question is, now you are in tough place. We already decided the patient is going to get Evolut by all the means, and now we have a RCA disease. So we said, well, have to go ahead and do our TAVR plan, which we had. The TAVR was placed, and then we say we're going to go through the stent struts of the TAVR Evolut to go to this right coronary artery. And actually, you can see if we can show that angiogram now quickly. So this is the TAVR valve done about 3 months ago. Patient has dyspnea, so not truly angina, but dyspnea. And you want to play, Anu? Minus first. Yeah. So we did one picture, as you can see here. Huh?
No, this is just, I have a fluorosave of how to probably engage. That means we have to go all the way into the, cross the, the TAVR valve. And then once you're in the LV, I pulled back and the same. What happens is, I think the new cage of the valve compared to the aorta, this is smaller. That's why you have to go with the smaller catheter. So what we have here is a no torque RCA, a 3D RC, or a no torque guide. That is what we have. And the guide is now sitting at the ostium of the RCA.
And see here. No, one second, show. We have the picture.
Okay, good.
So we just wanted to see. So where was it? So see, it is coming just above the leaflet, right at the bottom. And now Anu has manipulated going into the ventricle first and then pull back.
Yeah.
So where are we now? Do we have to take a picture? Are we a little more selective? This is right now we have a Akari one, yeah. So this one was the Noto guide of Cordis, and that didn't help us much, as you can see there.
Yeah,
And we
too
actually,
long also.
while
This
we are
will be
trying
too
to
big also.
engage, I'll tell you, go to the slides. So now this is our plan. Basically is complex PCI of the calcific RCA lesion with Evolut TAVR valve, struts using RA plus IVL, RotaTripsy, and of course we can do imaging. Now, this issue about the angiogram before and after with the CAD patient has been a big issue, as you know. So clearly, that many times we try to do PCI before, even with a significant lesion, but sometimes for some reason, patients particularly low risk come back later. So access post TAVR is very difficult or can be challenging. I would say not difficult, can be challenging. And this actually has been looked into, and we were the first one to publish this of the coronary angiography and PCI after transcatheter valve replacement state of the art review, which we published few years ago, and basically goes through the anatomical factors and the device and procedural factors which lead to this issue of engaging the coronary arteries. And we actually went through in the self-expanding valve, RCA, as you can see, FR4 guide, actually that's what Anu wants to use, or Akari guide. And of course, various guide support and so has been shown there. It all depends now. Many times you want to use now the commissural tab is not in front, and then of course you go to the various. It's I can tell you challenge multi-purpose guide which you suggested. We might end up in having it if nothing else goes MP, and so we have
Not
that.
MP,
So key is
yes.
this issue
FR maybe.
of coronary engagement has
What are
been
the Medtronic
assigned,
guides you
looked
have?
into it, the
Medtronic
re-access
guides, you
study.
have any?
Of the 300 patients with all available devices, 23 they were unsuccessful cannulate post, and 22 or 23 were the self-expanding valve Evolut Pro TAVI, and the transcatheter aortic valve, the implant depth, and sinus of Valsalva, all were independent predictor whether you can successfully cannulate or not. So now you want to talk about, while I'm doing this, Anu, of your TAVR cath aid.
Yeah, so initially we had released the first, which was the TAVR catheter, but we just actually updated on March 2021 a newer version, adding a lot of animation and live cases. How to do these cases in that app. So if you go next. So the new, what are the added features? Are added case reviews. More important is offline functionality. So if you don't have an internet connection, you still can access many of these cases. And user interface change, and more powerful search button within the app as well as outside with the detailed animation. So I'm going to show you the animation because I'm always a believer of animation. This is offline functionality, updated interface use, so that you see easy to use buttons, the search function within the app as well as each detail. So if we go to the detailed animation, so this is the animation we are showing, and this is what I showed you initially. So when you go first, so you can go from the side of the valve. So you have to go with the J wire to make sure you're inside the valve. So you're rotating it clockwise, and just take a J wire only. Here you are inside, again same. You see that with the wire, you go through the diamond strut. Though the animation is making it look like so easy, you see us still, struggling to get it here in live. So when you're taking it out also, you need a J wire rather than just remove the catheter by itself. This is the same animation playing. And what has happened also is, if you do not want to download the app, we have a full-featured web app where you can go to the website and see all these features that I just mentioned by itself. Where do you find the web app? On www.cardiologyapps.com with the TAVR cath. Yeah.
One moment, I just wanted to apologize to the viewers. For a moment, we had lost the audio. Let me know if you're having any issues still. Samin, please continue.
Okay. Yeah. So just give a little dive first. We're a little below still.
Maybe you have to just use the same. Okay, open that. This is the JR or LIMA.
And this is the JR now.
I mean FR guide.
FR guide. I mean, yeah. It's very challenging, but that's okay. That's what the whole purpose was. Struggle. Little
Give the
dive now.
diagnostic
I mean,
note
the
of
guiding
3D
catheter
RC.
is probably the biggest issue.
now.
Okay,
Little
then we have
dive
There you
some.
go.
No.
Almost.
now.
Yeah, that's FR guide. there.
FR. See, by our book, go with the FR guide. If we see, so if you go to the slides again quickly, and then we'll go to this angiogram. Don't advance anything yet till we get to it. So if you see here, I just want to go back to our point. So we saw that in the one of the most common catheter used will be your FR guide, RCA. See that? So this is what we used. FR, this is what we published 3 years ago. So anyway, so let's go back to this point, complete this case presentation, and we are ready with the patient is appropriate, did not have any stress test, but patient is on maximum medical therapy and with the symptoms, and that's where we are now. Anu? So okay, this is the picture. Go to the cine now. Fluoro, please. Okay, so this is the guide catheter. We are ready with the fielder and fine cross. We need an extra support, rota extra support wire. In this
Samin,
particular case,
No,
yeah.
why? It's
Yeah,
okay.
extra support. Yeah.
Roto floppy.
Yep. Yes.
We go with
Samin,
175
so
bar.
just from the data which you showed,
1.5.
there was a single patient out of those 22 out of
1.5.
23
Yeah.
who you could not cross.
Yeah. So that in the paper, they could not cross, and that case was, they used all of them. 1 second. Let's 1 second. Yeah. So they use, and now we are going to get our fine cross go. So, and that one case was the accurate, not accurate neo. So another valve. Yeah. So right now we are fielder and we are with the fine cross. Good. Now question is, this is the kind of case you will like to use the extra support wire, and I know 1.5 or 1.75 per.
Let's see how the.
Yeah. I think 1.5 is okay because we are going to use IVL combining it, right? Because it may make a little trouble. See, you're having a
we may
difficulty.
have difficulty in delivering the.
No, but with
IVL.
after
Let's go
1.5, IVL will be okay. Extra support wire ready. Always make a curve ready. Yeah, that's good. Leave it there. Wire will go. I know now.
Extra support wire may not go.
You will take a 3.5, 20. Good. Take the wire out. Yeah, prepare a 1.5 bar. Yeah.
Not 3.5. 20. Get us the 15 balloon.
So, I mean, there's a question which has come for you in the meantime. Have you done any of these cases via the radial route?
Well, actually, some, yes. I think we actually did publish in that, we wrote down in our review paper, and then subsequently we have another paper in International Journal of Cardiology by our experience cases. So majority is done by femoral, but I would say going through the core valve, radial, if we have at our center, we have done 50, 10 have been to the radial, and 40 have been femoral. Largely femoral just because of the support, as you can see here. But yeah, radial can be used nowadays. Is not a problem. But the tortuosity, guide support may be a little bit issue, but that is it. But yes, radial is, we did mention in our review paper that we prefer, unless there is some region, because you require a lot of manipulation of the catheters, a lot of exchanges, very high chance of spasm. So better you try the femoral approach, but there are some cases there is no femoral. So you have to go to the radial, yes. Okay, we have extra support wire and we have 1.5 bar, and the flush is all ready. So now you want to just take a little picture. We are happy with everything. The wire wear is gone. So
I mean, another
good.
question
Yeah.
question
Yeah.
for you. Ever had any displacement of the valve position with
Very
catheter manipulations?
okay. Very good point. So we haven't had anything yet, but there are in the literature actually there are 2 deaths because of the either catheter is stuck into the guide catheter is stuck into the valve and one embolized. So there are case reports, but we haven't had any at Sinai. But that's a potential, and that is where this which Anu made this TAVR cathode comes very user friendly. Go through the steps that how you avoid simply taking the catheter out. If it's between the strut will displace and may cause trouble. So make sure you put a wire to take them off. Yeah, ready?
Ready?
Yep, go. We are going in now.
I think as I had shown, very important, to get, you have to be in the center of the valve. To do that, you have to use the J, the J wire, which we showed you there.
Yeah.
Many times the J wire will not take you, then you can go with the straight tarumo, or angle tarumo, to get into any of the diamonds. Do we have the left-sided animation with the angioplasty?
Yeah, no, but no, this one I put only right side animation, but the left one is the same way. Left one.
We showed how to do PCI with just the catheter at the ostium of the diamond and then wire it. Maybe, Andrew, you can bring that other animation where we are doing a left-sided PCI with the guide liner.
Yep. Okay.
Good.
All right. Let's go now. So we are just at the ostium, and here tough and push and pull. You do manual a little bit further. Let's see if we can go. Otherwise, there is a difficulty. Then use the Dynaglide feature. Yeah, don't go Dynaglide. I think that will.
You already see it. Let me just show this again on fluoro.
Yeah.
So I'm advancing, but see the guide is coming out. So we'll leave it the way it is. We'll do Dyna mode and advance.
Yep.
So I'm on Dyna.
Yep.
You see that? Brake release.
Yeah, the seat. Yeah.
Yeah, do the brake release. So you're releasing the brake.
And advancer has to be taught.
Okay. And the Dyna.
Yeah.
So I'm going manually.
Yep.
Good. Stop.
That's good. That's it. See, we advanced it. So we were able to advance part of it by the Dynaglide mode. So therefore, don't push and pull your guide disengage everything. You work hard to get your engagement. Now we are done. Advance it. We have enough room to do the rotablation. Okay, Anu, go. Good. The technique remains the same way, but see RPM dropping. Yeah, this is the lesion. So idea is that avoid more than 5,000 RPM. Yeah, so significant drop in RPM, slow down. So that tells you anytime more than 5,000, it becomes a yellow light. I think they should show that also. More than 10,000 become red light. So basically means that you need to be a little slow in terms of this calcific vessel, although it's a 1.5 bar only. Yeah.
First of all, it was a very good decision to go with the 1.5, I think.
Yes. Yeah.
I mean, it was very deceptive, such a large vessel.
But you saw the tramp track sign completely. You don't need any imaging. So a lot of people say, well, I don't know. I need to see with the ultrasound. I say, well, yeah, but the angiogram is also, so don't underestimate. Yeah, we understand that many of the mild, moderate calcium you may not see with the angiogram, but the severe calcium is very clear, like in this case. And your IVUS catheter may not even go, or OCT may give even more trouble. So did not cross completely. You need a room. Yeah. Now good. Polish.
There we go.
Yeah.
I'm going to do one more polish run.
Yeah. So now that time I'll move the wire so that it will have a little directional rota. So in different directions.
What did you do? What did you do?
Sorry. Yeah.
Change it.
still not advanced. Move. Okay, good.
Stuck.
Yeah,
Don't
yeah,
move.
Yeah, good. Fine. Get a run through wire ready. Good. Okay. Good. Let's come out. Okay, we are coming out
ready?
now. After done the polishing.
I mean, to me, it seems the biggest possibly
thing away.
lesson regarding guiding catheter use for accessing TAVR is not to use any Amplats catheters.
Yeah. Oh, definitely in this one. Yeah. Amplats we have avoided. Even and then once you go to the VL or EBU, smaller one, 2.5, 3.
Yeah, particularly the removal of the Amplats can clearly displace the device.
Yeah. Okay.
Amplats will not engage.
Engage, yeah.
How things change. Once you have a TAVR valve, which is the Evolut valve with this big cage, everything changes. The anatomy changes. You don't have the, the so-called pliable aorta. Now you have this cage in front. So what will happen is the catheter sizes will all be smaller.
Good. Okay. Looking good here. So now question comes is twofold. So we have created a 1.5 lumen. The question is whether the rota will, with the IVL will go directly. And IVL should be 1:1 vessel ratio, 3.5. Yeah, let's try 3.5 before putting the balloon. So if cannot, then you do a balloon first and then put IVL. But we are going to go with IVL right now with a 3.5. Yep. No. Looking good so far, yeah.
Why are you not trying to dilate first?
No, I know, but this one we just wanted to show this combination because Burr would have been 1.75 and so. Yep. Good. Let's take other wire out. Rota comes out without trouble.
May not go.
Yeah. No, that will be the test. Let's take the rota wire out.
Then you may need a double wire even to get another.
No.
It's very, so it's stuck. Yeah.
Yeah, that's what I'm saying. Okay, good. And I'm so sorry for that audio visual issue, but I'm glad they were able to take care of it very quickly.
Don't go negative.
Can I get out?
Negative.
Yeah. They said no, they wanted to present negative.
No.
Yeah, no, they want this one to be negative. Yeah. Okay. All right.
Another question for you, your preferred guide wire to deliver IVL?
7.
Run through.
Your workhorse wire.
Workhorse wire. So whatever your workhorse wire is, in some cases it may be tortuous, and then you want to go with the floppy wire. If that is what your workhorse wire was, that is fine. And another advantage of the IVL is that you can use a 6 French guide liner or Godzilla compared to you cannot put any rotablation burr, even 1.25 through it. You need 7 French. And secondly, you can use sometimes the orbital atherectomy OA will go through the 6 French, but I know many times it's a struggle also.
How much of OA are you using now?
Yeah, OA actually is has significantly decreased now. So I would say that of the 23% atherectomy we are doing every month of our 350 cases of coronaries every month. Yeah, let's do it here. Good, that's good. Yeah, went in actually very nicely.
Okay.
Yeah.
So possibly.
So basically of the 23%, our 19 to 20% is basically our rota, orbital around 3% and laser 0.5. No, don't do it.
It's okay, we can dilate.
So IVL being the biggest increase.
Yeah. So IVL just, we had not collected full data yet because we just only few months, we are using it now. But yes, soon we will have, it will make it to the numbers also.
So Samin, how do you respond to the counter argument that RotaTripsy may be overkill? Why do you really need two complementary technologies?
I think last time you may said that you want to call it Rota Shock.
Yeah.
Why we just still calling?
So
Rota,
question is, so question is very important that whether the clearly in our algorithm, as you saw, maybe I'll show that algorithm once again. Let's go up here. Fine.
I have. Okay, I'm going.
Yeah.
It's ready?
Yeah.
Okay.
So we have
I'm
4
going up
atmosphere.
now.
What,
Yeah,
4?
I'm
Yeah,
4
good.
atmospheres.
Yep. Doing it now? No,
Yeah.
it's not doing it. Huh?
Yes. Hmm.
Go
Okay.
now. Yeah. Yeah. So key is that once you're done the rota, you do a balloon dilatation and you are expanded, then you are done. It's only, you should use IVL in those cases in a large vessel like this because of there is a suboptimal result. So what Anu said earlier, should we have, go negative first. Let
No,
it
we have to go.
reperfuse. No, let it reperfuse and then if you want, you can go to 6. Remember
That's
always
what I did,
ST
always.
elevation. So the same, you did a shock, fine, you wait few seconds and then you go back again, go to higher pressure. Same place or you want to bring proximally? Or you want distal?
Off before you go up?
No, I think just,
Huh?
I'm sorry, what?
No, he's saying STs go up.
Yeah, yeah. No, of course.
Yeah, but you see it's coming back down.
Yeah, yeah.
Once you give shockwave, then you go a little higher again and then come down.
Okay.
Okay, no, 4.
Yeah.
4.
4.
Okay.
Yes.
Okay, I'm going again.
You start. No, you do. You do. You're
No,
ready.
good.
Yeah. Yeah. So they just put once on. Yeah. Cine. So we can see.
I did.
So, Samin, how many
Ruptured.
total?
Balloon
total-
ruptured.
Yes.
No, this ruptured.
Mhm.
Huh? Yeah, that's fine. We're done. It's ruptured, right?
Yeah.
Yeah. Out. So
Okay, now
some
let us
cases
go.
of rupture do occur. We have the other our balloon. So calcific same way. Like any balloon can rupture, this balloon can ruptures also. But one of the important points which have been shown in many trials, that perforation compared to any atherectomy devices has been relatively low from the device. Many times you have after the stent and so. And actually I'm happy that now while we are completing our the dilatation and stenting, we are getting to the time and Dr. Mehran, which we announced expert on
Let
the
me show my
antiplatelet
animation,
therapy.
then you can start your antiplatelet.
Which animation?
At the left
Yeah.
side.
So we'll do, yeah.
The questions
So
are
share the
related to
nerve.
that.
Yep.
So, Dr. Sharma, I have a question.
Yeah.
With the lithotripsy balloon, if you're at a lower pressure, do you have less of a issue with balloon rupture, or is that just a higher pressure that might cause the rupture? Or why do you need to go any higher?
Six. We went only 6.
You only went up to 6,
Yeah,
Yeah,
and
4,
it's still
6, and 8.
ruptured.
You go to 4, 6, and 8. Reason is once vessel starts opening, you
Yeah.
need to be in touch. The
You need to keep
lithotripsy will
going a
work.
little bit
Yeah.
higher.
Yes, because it has to touch the calcium.
Well, that's very important.
Because of that, yes. Gradual increase in pressure. Now this is our 3.5, 15,
20, yeah.
20, 15 or 20. It looks like 15 balloon. Yeah.
Go up.
Okay.
Roxana, welcome to our webcast.
Hi, it's nice
let's
to be
see,
here again.
where is yeah,
It's lovely to
right
be
there.
here.
Yep.
Lovely to be here. Thank you.
3.5 or 4.0.
Roxana, I think
3.5, 33 Zans.
congratulations are
Giants are promos.
absolutely deserved today for Abbott Vascular for the approval of the Portico device.
Down.
Yeah, it's wonderful for them. Yeah, it's great.
I always say the spoiler will maybe we'll take a 38, right? Get a 38. Yeah. So spoiler is anytime you have 2 devices, they have monopoly in terms of the pricing. And we learned in the data of the DES.
Yeah.
Each were 3,000, then went down to 2,500. When the third one came, Medtronic, after the Abbott and the
Go.
Giants.
Very
Beautiful.
nice.
Yeah. So after the Abbott and Cypher, the Cordis. So when came, the prices became 1,500 to 2,000, and of course now the prices are 700, even lower because so many companies. So until now, these 2 devices, the valve devices, has a monopoly. They do have some volume discount, but each cost around 30,000+ each valve cost. TAVR valve compared to surgical valve is only 5,000. So we are 6 times more cost. Yes, We are early discharge. That is how the DRG of the SAVR and TAVR is about the same. Based on the comorbidities, you get around 92,000 per each case. But because of the high cost, clearly, which is partly compensated by early discharge, but still a lot of difference in terms of the cost of the device, that hospital contribution is much lower with the TAVR compared to surgical valve.
Look, particularly in the developing countries, I think the real advance of technology will happen only once the price comes down.
I wanted to also like point out one other thing about sort of coronary disease and in patients with TAVR, which we see very often, and the trial, the complete TAVR trial that's going to take off, and it's very fresh in my mind because yesterday we had an executive committee meeting with, and we're really excited about kind of this important prospective randomized trial for balloon expandable valves that will have in patients with concomitant coronary disease with revascularization being complete at the time of TAVR within 30 to 45 days after the successful TAVR versus leaving the coronary artery disease untreated. So it's going to be very, very interesting and an important one. And Mount Sinai will be one of the enrolling sites, and we're very, very excited about that. And as you see from the app that Dr. Kinney has developed in evaluating and getting into the coronaries after the TAVR, I think it's going to be a very, very good way to go post TAVR for revascularization. So we're excited about that.
Yep,
Dr.
that would
Sharma,
be a very good point. Is the field that patient with the CAD and AS, is it combining both as a prognosis or it's only the AS? And that is where some data showing that maybe it's only the AS, not the CAD. Remember, same thing happened with the mitral valve repair with the CABG or CABG alone. So adding CABG to the mitral valve replacement doesn't increase any mortality. So same kind of things, maybe that way. So we have the animation of the left system. Show the animation of the left, please, for the TAVR cathode. Yeah. This is the right one.
That's the right that she's developed. Bravo to Dr. Kinney with all these incredible apps, making life easier for the interventionalist.
Let's see.
Okay, another woman innovator.
So this is, can you start again? Start it again.
That's the RCA.
Okay,
there we
this
go.
is this is the left system. We are just showing you how to engage. So you have the catheter, and we are just showing you, this is a bird's eye view, exactly how to get into the diamond. So if you see there, there's a commissural post very close. So that is why you rotate clock, counter clock, and then you get into the diamond. So many times what happens, you can leave the guide at the diamond at the tip, and then you will wire. That's what we showed. You wire with the filter wire into the coronaries, and then once you have passed your balloon, you will have your guide liner or Godzilla into the vessel. So you see the guide catheter is at the diamond of the valve, but the Godzilla or guide liner has gone forward. And then you do your PCI. We have done even rotational atherectomy through this. And then how you remove it. You leave the wire there. You remove your Godzilla first. You remove your guide first, and you remove the wire along with that. So that kind of removal is very important to avoid the guide getting stuck or even dislodging the valve. There have been case report of valve dislodgement when they're trying to engage also. That is why you have to do this. So again, we are showing the same bird's eye view, how you get into each diamond. So you're just at outside.
So you sit outside and you just wire.
And then
beautiful.
You are doing your PCI. Nice. Balloon is there. Then you're advancing up to the left main. Do your PCI. Balloon comes out.
Okay, change.
This is the stent advancement.
Change the setting.
Stent STS coming out. Now the everything comes out gradually with
Beautiful.
the wire ahead of it.
Yeah, so
Very
key is
clear.
the
The
wire.
wire has to be ahead of it, and then you take the whole system out.
I mean, so the concept really is, in principle, very simple. Atraumatic guiding catheter without much manipulation, and the support is provided by the guide extension catheter.
That is it. Good. Wire is still very tough. Yeah, good.
Very nice. The result looked very good in the
Beautiful.
meantime.
Let's show it.
I'm wondering if
I was
you're
the
going with
OCT.
any post
Presentation,
expansion or something.
Yeah.
Right?
No, we did already. We dilated with the 1 second here, and I want to show it with the 3.75 at 20 atmosphere, as you see here.
Which
so we
is
dilated a few
4.0,
times. Yeah. So it's always became like a 3.89, and this is the final results. Excellent of this complex case. Look at that.
Very good. Excellent.
So I
beautiful.
think that's where the combination will be. We are starting a study called Rota Cut, combining Rota alone with the Rota plus cutting balloon with a smaller Rota bar. Maybe one day we'll be able to do the trial of the Rota Shock, that Rota alone, followed by high pressure dilatation, maybe bigger Rota bar versus a small Rota, followed by IVL, and to see which one gives you the better lumen.
Yeah,
so we do the OCT here, and of course Roxana is with a 2-center trial as a pilot for the for Boston Scientific right now. But there are many more will come, and
Can you have
of
the
course
pressure?
with Dr. Maran coming up with this kind of proposal, and now knowing that the IVL, they actually, while the device has been approved, still they have to do a lot of studies to really make its use, whether it's a bifurcation, left main, and all those situations. And this combined strategy, the device synergy has to continue.
No question.
Yeah.
No question. And I think this
Can you show the
idea
OCT?
of device synergy in these complex cases are
So,
tremendously
flashes are
important in
perfect.
improving outcomes, hopefully. We have to show it though.
Yeah,
Okay,
much better.
show that in the
Thank you.
main screen.
Yep. Can
OCT
everybody
on
see
the main
it?
screen.
Yeah,
One
I
second,
think
let
it's
them
there.
put the OCT on the main screen. Yeah. Yeah.
There we go. Okay. The moment of truth.
Yep.
Yeah, good image.
Wow.
Nice.
Okay. Okay.
Can you
Take the
do?
wire
okay.
out? No, wire.
I
leave
think
it
the
till-
concept
you know.
of
You don't
when
need
do you
it.
time your revascularization in a TAVR patient is a very important one.
I'll
We've
do
traditionally
correction.
done it before. You know, you do everything to take care of everything, but now with current generation valves and the apps that we have and access of coronaries, etc., is not an issue. What's your
No, I
current
mean-
strategy, Dr. Sharma?
Yeah. So
Let's
I mean,
wait 1 second. Let's
Oh,
see
sorry.
the
we
OCT.
were doing it. So no, I mean, idea there is that yes, you don't want to combine
Can
at
you
the same
explain?
time. Yeah.
Let's see this.
Okay, so I'll check. So this is a little bit movement because of the TF-TAVR vessel.
What happened?
So go to the distal. Yeah, looks like distal 360 calcium.
Yeah, a lot of
Yeah.
calcium. Yeah.
Yeah, this is the
But how is the lumen distally?
enough.
Enough. That's the key.
5.7.
Yeah. See that we had a lot of calcium. We showed that earlier.
And this is the distal edge of the stent. Yeah, looks very expanded, well opposed, and no clear edge dissection. And go to the plug.
Why is it jumping like that? Okay,
now.
now.
Yeah. So sorry, the angiochronicization didn't work well. So, but stent is well expanded,
Look at that.
Yeah.
Called proximal. Yeah, this
Go-
is outside. So go check that this.
Go back to the stent and give us a CSA.
Okay, so I check the CSA automatically. So like distal and proximal.
Yeah.
Okay, so almost distal part. Yeah, like it says 6.2. It's a
Okay.
CSA. MLA, MSA. Minimum stent area is 6.2. And well expanded, well opposed, and no edge dissection. I
But
think
6
perfect.
is still very low. I mean, you want a little bigger. Why 6 only?
What
That's
can
on
you-
the distal side though, right?
Yeah. So it's
But-
like tapering. Yeah, proximal part is like.
It's a tapered vessel, Dr.
Yeah.
Sharma.
So
You
much
see
of
how-
look at this
I
amount
think
of
it's
calcium.
Proximal part
it's
is
well
like
opposed. You're not going to get bigger
12.9.
than that.
You have to go with the opposition also, SS, not MSA in the
No,
heavy
he is at 10.
calcium.
Lumen is 10 now.
Yeah,
10.9.
proximal
No,
part
that's
is 10.
proximal.
Yeah.
But
In the
this is-
proximal, it's a tapered vessel.
Yes,
I
sir.
think it's very well opposed.
Okay.
in where it needs
Time
to
to
be.
leave it alone.
What is
According
the
to the
3D of
proximal
the
and
stent?
distal.
You have the longitudinal of the stent pictures. Where is
Yeah.
it?
Okay.
So if you see the longitudinal of the stent, the first bird's eye view, you don't see any red spot, which means it's well opposed.
Yes.
You see some red dots, that's
I
when
see.
it is telling you there's unopposed area, malopposed. So it's nicely opposed.
Very nice.
Yeah.
Well done.
Okay, I think we take this out, right?
Yeah. And we
Final
always
picture,
say,
low mag, final
last
picture.
low mag, try to see a distal vessels. Always we teach, and then we will go to our
We're going to see how you
discussion.
take the guide out, Dr. Kinney, too.
Yeah.
And then I have to show the guide out.
Remote.
Make sure the wire
Ready?
is there. Yeah, good.
Pacemaker is out.
Injecting beforehand. Good.
Very good.
Yeah.
Okay.
Okay.
No.
Fellows are nervous.
Yeah, there's a
Okay.
little
Now,
collector. to
Dr.
the
Kinney will show how
inside.
she takes the guide out
Okay, get us
using,
the
wire.
wire.
using her wiring
Yeah.
techniques.
So key is the JR. I mean, JR still will be able to come out easy, but key, very rarely we teach people to take the catheter out with the wire, because if there is some clot
Yeah.
on the tip, it dislodges. But in the TAVR cases, once
she
you're
already
engaging, you should
flushed
go.
it anyway.
You're already inside, so that you have no issue about any clot.
Yeah.
And then you advance the wire before taking it out. Wire should be ahead, and that's it. Yep, good.
Very good. Well done.
All right, so with that note, we continue go to the slides, please. Go to the today's, the main point. Tell them to give 20 of Lasix. Okay, Lasix. So we are going to talk about the three
Lasix.
key trials from European Society, Master DAPT, Stop DAPT 2 ACS and Ripcord 2. And then focus review of the month will be the DAPT de-escalation in ACS patient, improving balance between efficacy and bleeding. So basically, the trials which were presented, actually they were, I know Dr. Mehran was physically there for the sessions. There
Yeah.
were not too much interventional trials this time in ESC.
I think there
Right?
were some.
There were
I
like
mean,
4
I think
or 5 only.
I think it's, you have to take into account
Yeah.
the COVID pandemic. And I think you're going to see that. And the level of the trials were tremendous. The ones that were accepted are always the pivotal ones. And I think that's, it's just the way it is at ESC. And I think these are some pivotal important trials. Master DAPT is an interventional trial in
Yeah.
high bleeding risk patients. And as is Stop DAPT ACS, I think both really good trials
Yeah.
in
No,
our
I mean saying
patient.
the trials were there. There are a lot of very good non-interventional trials with the heart failure, with this and those. But I mean, from the interventional
ESC,
point of view,
remember,
like,
is
yeah.
a cardiology, is a main meeting for cardiology. So there's heart failure, there's EP,
Big
there
time,
is
yep.
there is prevention, there is hypertension.
Lot of them.
Of course.
Yeah.
So,
Okay.
and I think we
So
did
let's
great.
quickly go. We know that patient with a high bleeding risk, you want to abbreviate the DAPT duration, high bleeding risk definition, which is kind of similar, which have been in the earlier papers. So basically the concept was, until now we have the trials showing that in high bleeding risk patient, you can stop after 1 month or 3 months. Zion's 2890, which Dr. Mehran did, or the Onyx 1 month. So those were single arm trials. But what about in the randomized fashion? So that basically the whole point was, in a randomized fashion, you got 1 month of DAPT. Now, do you continue or you can stop it? So that basically was in this high risk patient of the DAPT using a special stent called Ultra Master of the Terumo, which is not available in United States yet, but basically showing that you abbreviate after 1 month. Majority of them were on ticagrelor, the clopidogrel, but other agents were there. But main point of the study is here. That is net adverse clinical endpoint at 1 year. This is patient got DAPT for 1 month, came back for follow-up, for the randomization. In one group, they immediately stopped it. Other one, they continued 2-3 months or longer. And that led to this overall 1 year outcome where exactly identical major adverse cardiac event and cerebrovascular event, while significantly lower major bleeding, and individual endpoints are shown here. So this was a very, very important trial, and more also somehow it showed that even stroke and TIA was lower with abbreviated DAPT, not necessarily intracranial bleed, and the shown. So Roxana, you want to comment on the
I
overall
think this
data?
is really important in the context of our listeners to understand that this is the first randomized trial in exclusively high bleeding risk patients, where they were assigned after about a month of their dual antiplatelet therapies to an abbreviated DAPT versus a prolonged DAPT, which would be as you discussed. So very important. The trial investigators did a great job. They actually put 3 important endpoints. You had to pass each of those endpoints. And, you know, when we designed with Dr. Sharma, the Twilight trial, we went after bleeding, and then we went after the ischemic events. Here, they did a 4,000 plus patients in high bleeding risk. They looked for non-inferiority in terms of net adverse clinical events in high bleeding risk patients. Then the next step was you had to pass now major adverse cardiovascular events. And then once you pass those 2 hurdles, then you can go for superiority in bleeding. And that's exactly what they showed. And you see how nice they showed that. This is a very important study. And you might say, well, what's new about this? Well, it kind of, I believe, check marks everything we did in Onyx 1, everything we did with Zion's 2890, that when we showed that 28 days versus 90 days was similar, you know that we just presented that actually at this meeting at ESC and published that simultaneously. So I think very important message that less is more for high bleeding risk patients, abbreviated DAPT.
Now, other controversy came that this was the ultramaster stent, only one stent was tried. But will it be true for others? Yeah, because we know the data on the Zions, we know the data on the Onyx, so it will be the same message no matter what type of stent you use, and same thing will be for the Synergy, although Synergy doesn't have the label yet. So this basically was the endpoint, and they put it very nicely in this one slide. Second, same issue, 1 month dual antiplatelet therapy followed by clopidogrel monotherapy in acute coronary syndrome. So see this now, aspirin is out, stop DAPT 2, shown. This is the acute coronary syndrome. Basically, earlier aspirin was discontinued, and now in these patients, whether you continue one agent or both agents was the trial design, which is shown here. And this is a little complex patient inclusion and exclusion, how they included the patient that stopped DAPT to ACS. So in master DAPT, there were some patients with acute.
There were a large number of patients with ACS.
But this was selected acute coronary syndrome patient trial. So basically, what they did is that either you continue both aspirin and clopidogrel for 1 year, or after 1 month you drop the aspirin and only continue clopidogrel for remainder of the time period, whether 1 year, 2 year, 5 year. Because a lot of people believe that maybe what you should continue now, not the aspirin, after your DAPT assigned DAPT duration, continue clopidogrel. You know that
the P2Y12 monotherapy.
Two data have shown that chronic use of those may be even beneficial. And basically, again, large number of patients. Now, this is a little complex.
This is important. Stay here on this, okay? So this was an acute coronary syndrome patient, and it's the largest acute coronary syndrome, 4,200, almost 4,200 patients. But think about how they did this. Their stop DAPT to ACS actually was a prospective randomized study, 3,000 patients. The stop DAPT to ACS in stop DAPT 2 was borrowed from an already presented and completed trial, stop DAPT 2, that included both ACS and non-ACS patients. So they got about 1,000 or 1,100 patients, 1,200 patients there. The most important thing there is that, are these two populations the same or different? And then they put it into this, they pooled those data and looked at this randomization. It's important to note that in the stop DAPT 2 ACS, some of the patients, but the majority of them, received clopidogrel, and some received prasugrel 3.75 milligrams per day, which is not a dose that we ever use, but this is a strictly Asian population in Japan, and that is what they use there in Japan, in 3.75 prasugrel. And then they showed the 1 month versus the 12 months. So I think it's really important that it's hard to understand, like, how do you do that? Can you do that? What's the statistical correction? How do you look at already presented trial and then bring it in? But listen, nonetheless, we have 4,200 patients moving forward with 1 month versus 12 months, and then going to a strictly clopidogrel monotherapy, not TICA monotherapy that's already been shown very, very well in both global leaders, Twilight, as well as in TICO, that is safe, effective, reducing bleeding complications. This is clopidogrel monotherapy in ACS patients. So
very interesting. So many of them, most of them were done with the radial approach, and as you can see, IVUS OCT was done in almost everybody.
Right, which is not what we do.
So
and
I'm just saying that anytime you talk about this monotherapy, make sure that you do imaging. That's the only way you can duplicate those results.
Right.
So to say that almost everybody got the, and as Dr. Maran pointed out, prasugrel and so were used in small dosage.
In the first month.
In the first month and so. So now basically what was the persistent depth, the very good compliance, but the results basically are here. Your NACE to 3.2 versus 2.8, 1 month versus 12 months. Even if you go to the individual points, if you can see a CV death, MI, stent thrombosis, stroke on the left side. Now you're a little nervous. Look at these graphs are correct. 1 month depth, slightly higher event rate compared to 12-month depth. Bleeding, lower bleeding with a 1 month depth. No question on the right side. But the left side, first time in acute coronary syndrome, despite the guidelines showing that you need to give more than 6 months to 12 months of depth, you stop it after 1 month, you continue clopidogrel, not the stronger agent which Twilight used the ticagrelor. Clopidogrel alone have a just p-value, you see the hazard ratio 0.99 to 2.26, which leads to this diagram, basically showing that higher myocardial infarction. Although bleeding was low, but MI was almost double, hazard ratio 1.9.
Can you go back to the previous, because I think it's really important to look at these curves for our audience so that they can see. So first of all, and also before, the one before. So look at how low, these event rates are extremely low, like 2% event rates. And the differential and the confidence intervals are actually wide, like from 0.8 to 1.62. So they're wide. And so it's telling you that was this actually powered for this very, very low event rate for a non-inferiority to actually be reached. So underpowered when you have a low event rate in a non-inferiority trial is it a very, very important point for everyone to listen. The next slide.
And that is why they put those 5,000 patients.
That's
they combined
right.
two trials.
You still need more than that, though, is what I'm saying. In order to show the non-inferiority, you probably need 10,000 patients. And now here you start to see the curve separating, but they're separating very early, and we think it's all from the MI, but what doesn't make sense to me is the separation of the curves in the TIMI major minor bleeds at 200 days as opposed to the 1 month where you're making a change. So why is it that the bleeding is separating much later? That, again, doesn't make sense to me. Now let's go to the next slide. And you see that most of this is driven by more myocardial infarctions, and we need to know what type, where did it come from, is it from the, and then I think, do you have the forest plot of the stop DAP 2 ACS versus the one from the previous one?
So I had that, but I took that out.
So I think that's important. But again, a reduction in bleeding, which you would expect to see, but a mortality increase is what makes me nervous. And I wonder, and there is where I want to better understand, is this clopidogrel on responsiveness? Because it goes against what we've seen with a ticagrelor monotherapy.
So now, Anu, you want to comment on this? I know she's also a strong believer of more clopidogrel. So first time now, a systematic way, compared to our other trials, global leaders and Twilight, where after 1 to 3 months we stopped, there was no increase. But now with the clopidogrel in acute coronary syndrome, we are having a trouble. Little higher definite stent thrombosis, little higher mortality. So, I know she's a clopidogrel believer.
No, I'm a clopidogrel believer, very strong believer for stable patients. For ACS, the question is how long? Maybe up to 3 months.
Well, I think what she's saying is a very good one. It's a de-escalation, and we're going to talk about de-escalation. I think this is telling you that not one size fits all for everyone, and there are certain patients where you will de-escalate, certain patients you will continue the potent agent. But clopidogrel monotherapy in an ACS patient, I get a little bit nervous. I've always said that we need to measure, make sure they're actually responding to clopidogrel before we stop aspirin.
Good. So basically, this showed more investigation needed, and now just these all have been kind of used in the European guidelines. So this is a very nice put things together which we have spoken now. Patient with acute coronary syndrome, based on the bleeding risk are the guidelines, very high bleeding risk on the right, high in the middle, and you can low in the left. Low bleeding risk, but high ischemic risk. You see the ischemic risk more on the left side. So clearly, very high, you can stop at 1 month. In a high, maybe go to 3 months of the dual. But then if it's a low and high ischemic risk, that's where you come with more complex P2Y12 or more potent P2Y12 inhibitors. And we know that has been shown that even in a patient with a low bleeding risk, that after 3 months of abbreviated DAPT and just continue ticagrelor will be good enough.
If you stay right there, I want to make sure everyone understands the importance of this, that the class 1 recommendation for ACS patients with low bleeding risk is a 12-month of aspirin and ticagrelor, or aspirin and prasugrel, especially if they undergo a PCI. But what I think was, tremendous from the ESC, based on the data that came from TICO and Twilight ACS, is this 2A recommendation for ticagrelor monotherapy after a month of aspirin and ticagrelor.
Right here, yep.
And that's an important addition to what we can do. Yep. Now, with this particular study coming forth, I think you may have a question whether or not you would go to clopidogrel monotherapy after a month. I don't think you can endorse that. We need more studies, as you suggested.
Yeah. So basically, after 3 months, they become a lead to Twilight, led to change in the guideline incorporation, both I would say global freedom and
global leaders as well.
Leaders, yes. Global leaders, and so that made it between 1 to 3 months. You can abbreviate and put, but it's not for clopidogrel. It has to be the ticagrelor. Yeah.
We don't have data on prasugrel,
exactly.
Unfortunately.
Even
though those same guidelines gave a higher recommendation for prasugrel over ticagrelor,
Yep.
we just don't have data at all on prasugrel monotherapy. I think it's really important. So if you're going to go to monotherapy, it's clopidogrel probably for the stable patients and ticagrelor for the ACS.
Absolutely. So just very quickly, the idea is that you patient with a CAD, you decide based on the angiography versus you use FFR, ripcord. One trial already showed in the past that they change in the strategy, but does it translate into an outcome? One, which was the part of the ripcord 2 trial, and basically was that compared to an open label, you do angiographic guidance versus FFR guidance, your cost and quality of life and other major endpoints are different. This was basically the trial, and basically showed overall, if you take it, the results of the trial, that 1100 patients, angiographic 500, angiography plus FFR, and that lead to procedure time more when you do FFR, more contrast use, more radiation. So, well, we say that's good enough. Maybe it will do something better. And then what did they find? The individual endpoints, which are going to be shown in the next slide. And that basically is lead to various results, what to do, medical therapy, PCI or CABG, and basically lead to the primary endpoint of the total hospital cost. No difference, actually slightly higher on the FFR, but not significant. Quality of life parameters were not different. And the individual MACE events, angio alone was 8.7, angio FFR 9.5. Again, no difference of incorporating FFR in the routine angiographic MACE. In this particular trial of the French people and so on.
So let's understand. This was in the UK.
Yeah, UK.
Lots of incredible investigators. Nick Crozan is a very highly respected investigator. And we have to congratulate them. These are very difficult studies to do. I mean, it was FFR, all of the non-culprit vessels as well as everything that was going on. And actually, if we looked, there was these were a low-risk patient population, and you can see that. And as a result, I think you're not really seeing the benefit, perhaps. I think there's no question. This is not saying that you shouldn't be. This isn't going against FFR-guided PCI. I think it's really important. This is FFR-guided diagnostic evaluation in every vessel. So that's an overkill, and I don't think any of us are doing that. And I think this kind of talks about what the current clinical practice is, that when you have a questionable lesion, there's no question that physiology helps you, improves outcomes. That's from all of the FAME studies. And just wasting your time and using physiology down every vessel is kind of not something that is that should be done. I think that's what we're seeing.
End up in putting some more stents for those purposes.
And it's a diagnostic. Yeah. Remember, it's diagnostic angiography.
So basically, is that systematic FFR did not change. So whatever you see angiography, that's a good enough. And remember, FFR has come to the limelight also in STEMI patients. Remember the flare?
Yeah, that's right.
So basically, it turns out to be that flower MI trial that basically patients with some situation, the FFR may not be the guidance. Your angiography may be a good guidance and so. So lastly, let's quickly finish it. DART de-escalation, very nice paper. This was our review. Basically is that various trials which have been looked into it, that you go from one agent, a stronger agent to different agent, let's say from clopidogrel, from ticagrelor or prasugrel to clopidogrel, high dose of prasugrel to a low dose of prasugrel. So many trials included in this de-escalation, which has been shown here in the network total trial involvement. These are the names on the trial. And basically is that what happens when you do de-escalate? Do you change any of the ischemic endpoint, or you change any bleeding endpoint? That basically, why do de-escalate? Very simple. One may be cost, but that's not the issue majority. Majority of the time is the bleeding. Mm-hmm. So, and everybody is concerned by de-escalation, whether from various combinations which they have shown here, that is it going to increase any the ischemic endpoint? So basically, or the bleeding endpoint. So basically, you see clearly on the bleeding point, the de-escalation is better. Ischemic endpoint, not different. And if you go, this was the central figure of the paper, that left side, the primary efficacy outcome, and the bleeding outcome on the right side, bleeding superior. Every trial of the de-escalation showed better bleeding, except the comparison in the de-escalation in the efficacy point of view, lot on the midline of the curve, but some trial data did show. And if you go individual one, that just if you take a cardiovascular death, was a little reduced, but overall death, no difference. There's no difference in stent thrombosis and stroke. So, Dr. Maran,
so let's talk about this, because this is really, really important. When you look at these meta-analyses and this particular central figure, you're like, okay, I'm going to de-escalate everyone. And that should not be the take-home message. First of all, this is a network meta-analysis which is combining multitudes of different trials, and it's not an individual patient data. It's summary statistics from the different, it's really a math exercise. And I want to make sure you all, everyone who's listening, understands why is it that we do randomized clinical trials. When you get this kind of a data, you want to now say this is a good hypothesis to undertake, because individual trials here were all underpowered. None of them met the criteria that they wanted to get. And of course, when you de-escalate from a strong to a less strong agent, you will reduce bleeding. The big question is, are you increasing the ischemic events like what we just saw in STOP-DACT ACS by combining these other trials? And I think it's very important to say that it's an interesting, plausible way in selected patients. Who are those patients? We do not know. And it's a really great hypothesis to be now evaluated in a large prospective trial, which we are currently designing.
Yeah. So that's a de-escalation is here to stay, but selected cases, you cannot make it the uniform statement. Particularly be careful in acute coronary syndrome. And if you do de-escalate, probably after you have to give some time period, whether it's a 1 month or 3 months, and based on the acute coronary syndrome separate. So let's put it together now. Interventional trials, DAP abbreviation to 1 month in high bleeding risk, thumbs up. DAP abbreviation to 1 to 3 months in ACS PCI, no good. FFR guidance for management of stable CAD, no good. depth de-escalation to clopidogrel or 5 milligram dose of prasugrel is associated with lower bleeding, but no difference in the ischemic endpoint. Therefore, except in patients with high ischemic risk, depth de-escalation post-PCI should be routinely practiced because of decreased bleeding. In many cases, especially in high bleeding risk patient, SAPT will suffice after 1 to 3 months of initial depth, and that was the classical of the master depth. So just complete our 3 questions. The following statements are true regarding the abbreviated duration of depth after PCI. Master depth trial showed similar efficacy in 1 month depth arm. Master depth trial showed lower bleeding in 1 month. Master depth trial had very good compliance of the assigned treatment strategy. Master depth trial showed higher stent thrombosis in 1 month depth arm, and master depth trial showed similar stroke in 2 arms. And wrong answer is there is no higher stent thrombosis. Second, following statements are true regarding the results of STEP DAP 2 ACS trial, except open label comparison of 1 month versus 12 months DAPT. Majority of the cases were done by radial approach. 1 month DAPT had similar MI compared to 12 month DAPT. 1 month DAPT had lower bleeding compared to 12 month DAPT. 1 month DAPT had similar death compared to 12 month DAPT. Answer is C. There was a higher MI, not the similar MI in the 1 month DAPT in this acute coronary syndrome trial. Following statements are true regarding the results of DAPT de-escalation in patients with ACS, except DAPT de-escalation is safe as shown by a few randomized clinical trials. DAPT de-escalation is associated with higher stent thrombosis. DAPT de-escalation is associated with lower bleeding. DAPT de-escalation is not associated with higher ischemic endpoints, and DAPT de-escalation is associated with lower cardiovascular death. So basically answer is the B is not associated with higher stent thrombosis the way it has been presented so far. So with that note, we conclude our today's excellent case presentation and didactic discussion with thanks to Dr.
Thank you for
Roxana
having me,
Naran.
Dr. Sharma. It's always a pleasure to come between
Samir,
two legends of
any
live
questions
cases.
so far? I know we had a little extra discussion. Yeah.
Comment I need to make. I think when you look globally, I think the real purpose in several developing countries for de-escalation is cost.
Yeah.
You know, so we need to look beyond the bleeding as well as also. Anu, very good case. Congratulations for the lovely app. Roxana, thank you for joining us. Excellent review of a very important topic. Samin, beautiful review. We conclude this case today, and hopefully you've learned many tricks, particularly relating to the use of guiding catheters for access for these cases. We'll join you October 19th, and till then, goodbye.